Good afternoon, my dear friends. Glad to see you. Today's lecture is about clinical anatomy of the abdominal wall. The abdomen is the part of the trunk between the thorax and the pelvis. The anterolateral abdominal wall is musculoponeurotic. Posteriorly, the wall includes the lumbar vertebral column and the posterior diaphragm that overlies the thoracic vertebra and lower ribs. The abdominal wall surrounds the anterolateral aspect of the abdominal cavity, where many important organs are located. The abdominal wall encloses the abdominal cavity containing the peritoneal cavity and housing most of the organs or viscera of the alimentary system and part of the urogenital system. Although the abdominal wall is continuous, it is subdivided for descriptive purposes into the anterior wall, right and left lateral walls or flanks, and the posterior wall. The boundary between the anterior and the lateral walls is indefinite. Consequently, the combined term anterolateral abdominal wall, extending from the thoracic cage to the pelvis, is often used. The anterolateral abdominal wall is bounded superiorly by the cartilages of the 7th through 10th ribs and the xiphoid process of the sternum, and inferiorly by the inguinal ligament and pelvic bones. The wall consists of skin, subcutaneous tissue, superficial fascia, muscles and their aponeurosis, deep fascia, extraperitoneal fat, and parietal peritoneum. The skin attaches loosely to the subcutaneous tissue, except the umbilicus, where it adheres firmly. Clinicians subdivide the abdominal cavity into 9 regions to locate abdominal organs or pain sites: right and left hypochondrial, right and left lateral or lumbar, right and left inguinal, groin, epigastric, umbilical, and pubic or hypogastric. For more general clinical descriptions, clinicians use 4 quadrants of the abdominal cavity: right upper, right lower, left upper, and left lower. The 9 regions are delineated by 4 planes: 2 horizontal, subcostal plane passing through the inferior border of the 10th costal cartilage on each side, transtrabecular plane passing through the iliac tubercles and the body of the 5th lumbar vertebra, and 2 vertical planes. They are midclavicular planes passing from the midpoints of clavicles to the midinguinal points. The midpoints of lines join the anterior superior iliac spines and the superior edge of the pubic symphysis. The 4 quadrants are defined by 2 planes: transumbilical plane passing through the umbilicus and intervertebral foredisc between the 3rd and the 4th vertebra; median plane passing longitudinally through the body, dividing it into right and left halves. On this picture you can see different kinds of divisions of the anterolateral abdominal wall. The left part of the slide shows you the division into 9 subregions, and the right part shows the division into 4 quadrants consequently. This illustration demonstrates that the anterior abdominal wall is divided into 9 regions by 2 transverse lines: the transpyloric plane and intratrabecular plane. 9 regions, and among them 3 paired regions and 3 unpaired. The names of those regions. Chief layers of the abdominal wall include: the most superficial one is the skin, then deeper superficial fascia, the subcutaneous tissue, which forms the thin single layer above the umbilicus. Below the umbilicus, it is divided into 2 layers. First one is the fatty superficial layer, called Camper's fascia, and the second one, the deep layer, called Scarpa's fascia. Blood vessels and nerves run between these 2 layers. Next layer is muscular layer, then fascia, and then parietal peritoneum. Here you can see those layers from the surface to the depth. The superficial fascia divisions below umbilicus. Fatty layer, Camper's fascia, is continuous with the superficial fascia over the rest of the body. Membranous layer, Scarpa's fascia, passes over the inguinal ligament to fuse the deep fascia of the thigh, fascia lata, approximately 1 finger breadth below the inguinal ligament. In the middle, it is not attached to the pubis, but instead forms the tubular sheath for the penis or clitoris. In the perineum, it is attached on each side to the margins of the pubic arch and is known as Cole's fascia. The major functions of the abdominal wall include providing a durable and flexible covering to prevent the abdominal viscera from leaving the abdominal cavity, protecting internal abdominal organs from trauma or injury, maintaining the anatomical position of the abdominal organs, assisting expiration by pushing the abdominal organs towards the diaphragm, assisting in coughing and vomiting by increasing intra-abdominal pressure. The facial layers from superficial to deep include the subcutaneous tissue or superficial fascia in the structure of the subcutaneous fat, which lies deep to the skin and contains a variable amount of fat. Inferior to the umbilicus, the subcutaneous tissue is composed of 2 layers, a superficial fatty layer, Camper's fascia, and the deep membranous layer, Scarpa's fascia. The intestine fascia, epimysium, covers the external aspects of the 3 muscle layers of the anterolateral abdominal wall and via aponeurosis. The under-abdominal fascia is a membranous sheet of varying thickness that lines the internal aspect of the abdominal wall. Although continuous different parts of the fascia can be named according to the muscle or aponeurosis it is lining. For example, the portion lining the deep surface of the transversus abdominis muscle or aponeurosis is the transversalis fascia. The parietal peritoneum lines the abdominal cavity and is located internal to the transversalis fascia. It is separated from the transversalis fascia by a variable amount of extraperitoneal fat. This picture also shows you the layers of the abdominal wall: skin, subcutaneous tissue, muscles, 3 layers of oblique muscles, then extraperitoneal fat, and of course transversalis fascia, extraperitoneal fat, and parietal peritoneum. The anterior abdominal wall is supplied by following vessels: via superior epigastric artery, inferior epigastric artery, deep circumflex iliac artery, superficial epigastric artery, superficial circumflex iliac artery, lower intercostal and subcostal arteries, muscle phrenic artery. On this illustration, you can see the way of the vessels that supply the abdominal wall. As you can see, the superficial epigastric artery right here in the structure of the subcutaneous tissue, and the superficial circumflex iliac artery also is located superficially. These are the superficial branches of the femoral artery that arise from the femoral triangle, and they go to the abdominal wall in the structure of the subcutaneous tissue. The first artery, I mean the superficial epigastric artery, goes towards the umbilicus, and the second one, I mean the superficial circumflex iliac artery, goes towards the iliac spine. Those vessels form the superficial layer. They are in the subcutaneous fat. But also there are vessels that are located deeply between the transversalis fascia, under this transversalis fascia, and those vessels are the inferior epigastric artery from the external iliac artery. The superior epigastric artery is the continuation of the arteria thoracica interna, and deep circumflex iliac artery. And of course, the superior part of the abdominal wall is supplied by the branches of the lower intercostal arteries. Superficial subcutaneous veins here are abundant and well developed. There are thoracoepigastric veins running longitudinally which connect the lateral thoracic and superficial epigastric veins. A venous anastomosis between the superficial epigastric or femoral vein and the lateral thoracic axillary. Femoral means that the superficial epigastric vein drains to the femoral vein. And axillary on this line means that the lateral thoracic vein is the tributary of the axillary vein. The thoracoepigastric vein provides a potential collateral pathway for blood normally draining via the inferior vena cava to return the heart via the superior vena cava when the inferior vena cava is blocked. On this picture you can see the superficial veins of the anterolateral abdominal wall that form the clinically important anastomosis. The anastomosis between the inferior vena cava and superior vena cava, and the anastomosis with the tributaries of the portal veins. And in case of blockage of those main veins, the veins of the abdominal wall that are located within the subcutaneous tissue are enlarged, and we can see those veins, and this clinical sign is called the caput of Medusa. The superficial lymphatic vessels of the abdominal wall accompany the subcutaneous veins. Those superior to the umbilicals drain mainly to the axillary lymph nodes, whereas those inferior to it drain to the superficial inguinal lymph nodes. The deep lymphatic vessels accompany the deep veins and drain to the external iliac, common iliac, and lumbar, caudal and aortic lymph nodes. Superficial lymphatics of the anterolateral abdominal wall, superior to umbilicals, drain to the axillary lymph nodes. A few drain medially and deeply to the parasternal and anterior diaphragmatic lymph nodes, and inferior to the umbilicals, drain to the superficial inguinal lymph nodes. Thus, in case of different type of cancer, for example, such as malignant tumors of the skin or maybe other types of tumors, we should examine both the axillary lymph nodes and the inguinal lymph nodes to determine metastasis. On this picture you can see the arteries and nerves of the anterolateral abdominal wall. Nerves. Nerves of the anterior abdominal wall include 6 inferior intercostal nerves, subcostal nerve, iliohypogastric nerve, ilioinguinal nerve. Here you can see the picture of spread of the nerves. The 5 muscles in the abdominal wall are divided into groups. The first group includes 2 vertical muscles situated near the midline of the body, and the third group includes 3 flat muscles located laterally and stacked on top of each other. The 3 flat muscles include the external oblique, internal oblique, and transversus abdominis. The flat muscles flex and rotate the trunk. Because the fibers of these muscles crisscross and interlink with each other, they also strengthen the abdominal wall and reduce the risk of herniation. Here you can see the muscles, the flat muscles of the abdominal wall, layer by layer. The external oblique muscle is the most superficial and also the largest flat muscle of the abdominal wall. It runs in an inferior medial direction and at the midline. Its fibers form an aponeurosis and the midline merge with the linea alba. This fibrous structure extends from the xiphoid process to the pubic symphysis. The scheme of the external oblique muscle, musculus obliquus abdominis externus. This table illustrates you the main information about the external abdominal oblique muscle. You can see that its origin from the external surfaces of the ribs from the 5th till the 12th. Insertion linea alba, pubic tubercle, anterior half of iliac crest. Action bilateral contraction, trunk flexion, compresses abdominal viscera. Expiration unilateral contraction, I mean one muscle. When only one muscle contracts. This movement provides the trunk lateral flexion, ipsilateral, trunk rotation, contralateral, innervation, motor innervation into costal nerves from the 7th till the 11th, and subcostal nerves the 12th. Sensory, iliohypogastric nerve from the first lumbar root. Blood supply, lower posterior intercostal arteries, subcostal artery, deep circumflex iliac artery. External abdominal oblique is the largest and most superficial of the lateral abdominal muscles. It lies beneath the thoracic and abdominal skin, covering the internal abdominal oblique and anterior halves of the ribs and intercostal muscles. Its muscular part contributes to the lateral part of the abdominal wall. Its eponeurotic part, however, contributes to the anterior abdominal wall as it contributes to the anterior layer of the rectus sheath. The superior, medial, and inferior margins of this muscle relate to their respective attachment points, while the posterior margin is free. This is in contrast to the other lateral abdominal muscles, all of which attach to the thoracolumbar fascia and their posterior ends. The portion of the inferior margin of this muscle that extends between the aces and pubic tubercle curves posteriorly, forming thick incurve or canal called the inguinal ligament of Poupart. The Poupart is according to the aorta, which constitutes the floor of the inguinal canal. Internal oblique, located deeper to the external oblique and is much thinner and smaller. Its fibers run superior medial and near the midline from the aponeurosis, which contribute to the linea alba. Transversus abdominis, the deepest of the flat muscles, and its fibers run transversely. It also continues to the linea alba in the midline. Just beneath the transversus abdominis muscle is the transversalis fascia. This picture shows you the scheme of the internal abdominal oblique muscle. As its name suggests, the direction of its fibers are obliquely oriented, perpendicular to those of the external abdominal oblique. The facts about the internal abdominal oblique muscle. Origin: anterior 2/3 of iliac crest, iliac pectineal arch, thoracolumbar fascia. Insertion: inferior borders of the ribs from 10th to 12th. Linea alba, pubic crest, and pecten pubis. Action: bilateral contraction provides trunk flexion, compresses abdominal viscera, and expiration. Unilateral contraction provides trunk lateral flexion, ipsilateral, and trunk rotation, ipsilateral. Innervation: intercostal nerves from the 7th till the 11th, subcostal nerve T12, iliohypogastric nerve, first lumbar root, ilioinguinal nerve, also the same root. Blood supply: lower posterior intercostal and subcostal arteries, superior and inferior epigastric arteries, superficial and deep circumflex arteries, posterior lumbar arteries. Aponeurosis of abdominal internal oblique muscle. The internal oblique muscle fibers can be divided into the anterior, lateral, and posterior fibers. Anterior fibers traditionally are thought to rise from the lateral 2/3 of the superior surface of the inguinal ligament, forming a common attachment with the iliac fascia. However, it is now known that they arise from a deep structure known as the iliopectineal arch. The fibers pass inferior medially, arching over the inguinal canal, and merge with the tendinous fibers of the transverse abdominis muscle to form the conjoint tendon. This tendon then inserts into the pubic crest and pecten pubis. In males, some of the anterior fibers extend into the spermatic cord and from the cremaster muscle. Lateral fibers originate from the anterior 2/3 of iliac crest and then diverge superiorly and medially, The fibers then extend into an aponeurosis that contributes to the formation of the rectus sheath and inserts the linea alba. Posterior fibers originate from the posterior end of the iliac crest and the thoracolumbar fascia. The fibers then ascend superolaterally and insert into the inferior bodies and tips of lower 3-4 ribs and their cartilages. Here, these merge with the internal intercostal of the aforementioned ribs. So, musculus cremaster muscle. As you can see, it is the continuation of the internal oblique muscle. Its fibers spread to the spermatic cord as a layer of the structure. So, the lateral fibers originate from the anterior 2/3 of iliac crest and then diverge superiorly and medially. The fibers then extend into an aponeurosis that contributes to the formation of the rectal sheath and inserts at the linea alba. Remember these facts about this muscle. Once again, posterior fibers originate from the posterior end of the iliac crest and then the thoracolumbar fascia. The fibers then ascend superolaterally and insert into the inferior bodies and tips of the lower 3 or 4 ribs and their cartilages. Here, these merge with the internal intercostals and the aforementioned ribs. Then, transverse abdominis muscle. As its name suggests, the fibers of transversus abdominis are oriented transversely, perpendicular to the linea alba. Together with the other abdominal muscles, transversus abdominis is important for maintaining normal abdominal tension and increasing intra-abdominal pressure. The transversus abdominis aponeuroses make up the posterior wall of the rectus sheath, which cover the posterior upper 3/4 of rectus abdominis, together with the aponeuroses of the internal abdominal oblique muscles. On the other hand, the aponeuroses of the transversus abdominis and internal abdominal oblique converge with the aponeuroses of external abdominal oblique, anterior to the rectus abdominis and from the lower quarter of the anterior wall of the rectus sheath. The point at which they converge is known as the arcuate line and is located 2.5 centimeters below the umbilicus. Key facts about the transversus abdominis muscle. Its origin: internal surface of costal cartilages of ribs from 7th to 12th. Thoracolumbar fascia, anterior 2/3 of iliac crest, iliopectineal arch. Insertion: linea alba, aponeurosis of internal abdominal oblique muscle, pubic crest, pectinal line of pubis. Action: the lateral construction provides compressed abdominal viscera and expiration. Unilateral contraction provides trunk rotation. Ipsilateral rotation. Innervation: intercostal nerves from the 7th till 11th, subcostal nerve, iliohypogastric nerve, ilioinguinal nerve. Blood supply: lower posterior intercostal and subcostal arteries, superior and inferior epigastric arteries, superficial and deep circumflex arteries, posterior lumbar arteries. Some facts about rectus abdominis. They are the long paired vertical muscles located on either side of the midline. The rectus abdominis is divided into two segments by the linea alba. The lateral border of the muscle is called the linea semilunaris. At several locations, the muscle is intersected by fibrous intersections, which give rise to the six-packs seen in athletes. The rectus abdominis compresses the abdominal viscera, prevents herniation, and stabilizes the pelvis during ambulation. Here you can see the segments of the rectus abdominis, which are divided by tendinous intersections. Among the vertical muscles, we know the pyramidalis. They are vertical muscles shaped like a triangle. It is located superficial to the rectus abdominis and located at the base of the pubic bone. The apex of the triangle attaches to the linea alba. Below the costal margin, the upper three-quarters of the aponeurosis of internal abdominal oblique muscle split into deep and superficial layers around the rectus abdominis muscle. The deep layer, together with the aponeurosis of transversus abdominis, form the posterior layer of the rectus sheath. The superficial layer, on the other hand, merges with the aponeurosis of external abdomen oblique to form the anterior layer of the rectus sheath. Around the level of the lower quarter of the aponeurosis, on the internal abdominal oblique muscles, the aponeurosis of the external abdominal oblique, internal abdominal oblique, and transversus abdominis converge and lie anterior to the rectus abdominis muscle. The point at which they converge is known as the arcuate line and is located roughly 2.5 centimeters below the umbilicus. The rectus sheath is an aponeurosis formed by the 5 muscles of the abdomen. It has an anterior and posterior wall for most of its length. The anterior wall is formed by the aponeurosis of the external oblique and half of the internal oblique. The posterior wall is formed by the aponeurosis of the half of the internal oblique and transversus abdominis. About midway between the umbilicus and pubic symphysis, there is only the anterior wall of the rectus sheath and no posterior sheath. At this junction, the rectus abdominis muscle is in direct contact with the transversalis fascia. The area of transition at which the posterior wall disappears is arcuate line. Immediately superior to the umbilicus, the rectus sheath consists of the anterior and posterior components. The anterior sheath is composed of the aponeurosis of the external and internal abdominal oblique muscles, and the posterior sheath consists of the posterior aponeurotic lamina of the internal oblique and the aponeurosis of the transversus abdominis muscle. The rectus sheath, inferior to the arcuate line of Douglas, consists of an anterior portion made up of fibers from the aponeurotic layers. The posterior portion at this point comprises only transversalis fascia, convert internally by peritoneum. On this picture, you can see the patterns of midline decussation of the aponeurosis. On the A, you can see single anterior and posterior lines of decussation. B shows you single anterior and triple posterior lines of decussation, and C triple anterior and posterior lines of decussation. This picture also demonstrates you the differences between the structure of the rectus sheath above and below the umbilicus. Linea alba. The translation from Latin is white line. Is a tendinous, fibrous raphe that runs vertically down the midline of the abdomen. It extends between the inferior limit of the sternum and the pubis, separating the rectus abdominis muscles. In leaner, more muscular individuals, it is visible externally as a longitudinal shallow groove. Linea alba is formed by the interlacing aponeuroses of three vertical abdominal muscles: external oblique, internal oblique, and transversus abdominis muscle. The aponeuroses of internal oblique, external oblique, and transversus abdominis muscles extend vertically across the anterior aspect of the abdomen. While crossing over the opposite side, their aponeurotic fibers interweave along the midline of the abdomen, forming the thickening known as the linea alba at the decussation. This interlacing takes place between matching layers of corresponding muscles and also between different muscles. In addition, the various aponeurotic layers, superficial, intermediate, deep, are also intervening between them. Linea alba generally lacks blood supply and innervation by a few small blood vessels cross the opposite side over its anterior surface. Due to this, it is a common incision and puncture site in abdominal surgery and suprapubic bladder catheterization respectively. The umbilicus is located slightly inferior to the midpoint of the linea alba, separating the latter into two halves: a wider supraumbilical part and thinner infraumbilical part. The linea alba is widest around the umbilicus. Its width and thickness also vary depending on weight, age, and sex. It is wider and thinner in overweight individuals, people past their 50s, and women, especially those with a history of multiple advanced pregnancies. A few tendinous structures in the surrounding area have fibers which blend with the linea alba. Upward directed medial fibers from the inguinal ligament close to its attachment. Extraperitoneal connective tissue and course the parietal peritoneum to the linea alba. The overlying membranous layer of abdominal subcutaneous tissue, scapus fascia, of the anterior abdominal wall blends with the linea alba in the midline. The fatty layer of the abdominal subcutaneous tissue, campus fascia, is located on top of the membranous layer and is continuous over the linea alba, whereas the deep adipose layer is absent at the fusion site between the membranous layers and the linea alba. Here you can see the posterior aspect of the anterolateral abdominal wall, showing peritoneal ligaments, folds, and fosses. The internal surface of the anterolateral abdominal wall is covered with transversalis fascia, a variable amount of extraperitoneal fat, and parietal peritoneum. The infraumbilical part of the surface of the wall exhibits several peritoneal folds, some of which contain remnants of vessels that carry blood to and from the fetus. 5 umbilical peritoneal folds, 2 on each side and 1 in the median plane, pass toward the umbilicus. The median umbilical fold extending from the apex of the urinary bladder to the umbilicus, covers the median umbilical ligament, the remnant of the urethras that join the apex of the fetal bladder to the umbilicus. Two medial umbilical folds, lateral to the median umbilical fold, cover the medial umbilical ligaments formed by the occluded parts of the umbilical arteries. Two lateral umbilical folds, lateral to the medial umbilical. The depressions lateral to the umbilical folds are peritoneal fossa, some of which are potential sites of a hernia. The location of a hernia is one of these fossa determines how the hernia is classified. The shallow fossa between the umbilical folds are the supravesical fossa between the median and medial umbilical folds, formed as the peritoneum reflects from the anterior abdominal wall onto the bladder. The level of the supravisceral fossa rises and falls with filling and emptying of the bladder. Medial inguinal fossa between the medial and the lateral umbilical folds, areas also commonly called inguinal triangles or Hasselbalch triangles. These are potential sites of direct inguinal hernias. Lateral inguinal fossa, lateral to the lateral umbilical folds. These include the deep inguinal rings and are potential sites for the most common type of inguinal hernia, I mean the indirect inguinal hernia. Here you can see the inguinal ligament, colored in green. Surgeons need to understand the anatomy of the abdominal wall so that the correct incision is made when entering the abdominal cavity. Here you can see different types of surgical approaches that allow to enter the abdominal wall to reach different organs in different levels of the abdominal cavity. Among them are vertical, horizontal, and oblique and combined incisions. For example, subcostal, paramedian, midline, McBurney, Pfannenstiel, and transverse. The consequently numbers. The scheme of those approaches is: a midline incision is made through the linea alba with a slight curve at the umbilicus. The linea alba is poorly vascularized and hence blood loss is minimal, and no nerves are excited. This is perhaps the most versatile incision when approaching the abdominal organs. A paramedian is an incision made just lateral to the linea alba. It provides access to the kidney, adrenal, and spleen. However, this incision is rarely used today as it required ligation of blood vessels and cutting of nerves. A transverse incision is made below the umbilicus. It was once used, but since it has poor healing, this incision is rarely used today. Pfannenstiel or suprapubic transverse incision is made just a few centimeters above the pubis. Prior to making this incision, the bladder must be emptied, decompressed, first to prevent injury. Subcostal incision is made just below the rib cage and allows access to the spleen and gallbladder. It is a limited incision with restricted exposure. McBurney's incision consists of splitting the muscle fibers instead of cutting them. It is located a third of the distance from the anterior superior iliac spine and the umbilicus. It's widely used during an appendectomy. The major pathology of the anterior abdominal wall hernias that include the following: umbilical, femoral, inguinal, ventral, incisional, Spigelian. If you know the most common sites for the abdominal hernias, so-called weak places of the abdominal wall are linea alba abdominis, umbilicus, inguinal canal. And of course, as the rear side of the rear type of abdominal hernias is the Spigelian line. The points that show you the sites of location of different types of abdominal hernias. Hernia of linea alba, umbilical hernia, hernia at linea semilunaris Spigelian hernia, in other words, incisional hernia, postoperative scar hernia, the synonym. A hernia is the abnormal exist of tissue, of tissue or an organ, such as the bowel, through the wall of the cavity in which it is normally resides. Hernias come in a number of types. Most commonly, they involve the abdominal, specifically the groin. Groin hernias are most commonly of the inguinal type, but may also be femoral. The picture that demonstrates you the hernia and its parts. All hernias have the hernial sac and the hernia porta or gate. The most common hernias develop at sites where the abdominal wall has natural openings, such as the internal inguinal ring, the umbilicus, and the esophageal hiatus. Previous surgical entry sites, incisional hernia, are also common areas where hernias develop. Factors that increase the pressure in the abdominal cavity, such as obesity, heavy lifting, coughing with chronic lung disease, straining during a bowel movement of urination, prostatism, chronic lung disease, and ascites have traditionally been considered important in the etiology, especially at these natural openings. Inguinal hernia. Inguinal hernias are the most common type of hernia. These occur when the tendinous pass through a weak spot or tear in the lower abdominal wall, often in the inguinal canal. This type is also more common in men. On this picture you can see the differences between the inguinal hernia that is located above the inguinal ligament and femoral hernia below the inguinal ligament. A parasagittal section through the layers of the anterior abdominal wall and groin. Observe that the transversalis fascia is depicted as a bilaminar structure. The inguinal canal and its walls, anterior wall, medially, this is the external oblique aponeurosis, laterally, external oblique and origin of the internal oblique from the inguinal ligament. The lateral part is the strongest, where it lies opposite the weakest part of the posterior wall, the deep inguinal ring. Posterior wall of the inguinal canal, medially, conjoined tendon and fascia transversalis, Laterally, the fascia transversalis, the medial part of the strongest, where it lies opposite the weakest part of the anterior wall, superficial inguinal ring. Roof, arching fibers of the internal oblique and transversus abdominis muscles, and floor, the inguinal ligament, and at its medial end, the lacunar ligament. Deep inguinal ring, in Latin annulus inguinalis profundus. Inguinal ligament and superficial inguinal ring. Below the free lower border of transversus abdominis, the transversalis fascia communicates with both internal and external oblique, as well as the inguinal ligament, approximately 1.5 centimeters above the midpoint of the inguinal ligament. The transversalis fascia contains a round opening called the deep inguinal ring. Along the medial border of the deep inguinal ring, the free lower borders of transversus abdominis occasionally gives off a band of fibers called the interfoveal ligament. The iliopubic tract is a fibrous band that runs parallel and posterior deep to the inguinal ligament. The iliopubic tract reinforces the posterior wall and the floor of the inguinal canal. The inguinal canal is formed in relation to the relocation of the gonad, testis and ovary during the fetal development. The inguinal canal in adults is an approximately 4 centimeters long, inferomedially directed oblique passage between the superficial and deep inguinal rings that runs through the inferior part of the lateral abdominal wall. The inguinal canal lies parallel and just superior to the medial half of the inguinal ligament. The main structure in the inguinal canal is the spermatic cord, conveying the ductus deferens in males and the round ligament of the uterus in females. The inguinal canal also contains blood and lymphatic vessels and the ilioinguinal nerve in both sexes. The inguinal canal has an opening at each end. The deep internal ring, the internal entrance to the inguinal canal, is an elongation of the transversalis fascia, superior to the midline of the inguinal ligament and lateral to the inferior epigastric vessels. The superficial or external inguinal ring, the exit from the inguinal canal, is a slit-like opening in the aponeurosis of the external oblique superolateral to the pubic tubercle. The lateral and medial margins of this structure. The deep and superficial inguinal rings do not overlap in adults because the inguinal canal takes an oblique path through the aponeurosis of the abdominal muscles. Consequently, increases in intra-abdominal pressure force the posterior wall of the canal against the anterior wall, closing this passageway and strengthening the potential defect of the abdominal wall. Simultaneous contraction of the external oblique also approximates the anterior wall of the canal to the posterior wall and increases tension of the crura. Contraction of the internal oblique and transversus abdominis muscle makes the roof of the canal descend, which constricts the canal. All these events occur during acts such as sneezing, coughing, and bearing down Valsalva maneuver to increase intra-abdominal pressure for elimination. The inguinal canal has two walls, anterior and posterior. Also it has a roof and a floor. As we just know from the previous illustrations, anterior wall is formed by external oblique aponeurosis throughout the length of the canal. The anterior wall of the lateral part of the canal is reinforced by the lowermost fibers of internal oblique muscle, and posterior wall formed by transversalis fascia The posterior wall of the medial part of the canal is reinforced by the measuring of the pubic attachments of the internal oblique and transversus abdominis. Roof, formed laterally by transversalis fascia, centrally by the muscle aponeurotic arches of internal oblique and transversus abdominis muscles, and medially by the medial cross and intercrural fibers. Floor of the inguinal canal is formed laterally by the iliopubic tract, centrally by the superior surface of the garter-like inguinal ligament, and medially by the lacunar ligament. Spermatic cord. The spermatic cord contains structures running to and from the testis and suspends the testis in the scrotum. The spermatic cord begins at the deep inguinal ring lateral to the inferior epigastric vessels, passes through the inguinal canal, exits at the superficial inguinal ring, and ends in the scrotum at the testis. Facial covering derived from the anterolateral abdominal wall during the prenatal relocation of the testis include the following moments: internal spermatic fascia, derived from the transversalis fascia and the deep inguinal ring; cremasteric fascia, derived from the fascia of both the superficial and deep surfaces of the internal oblique muscle; external spermatic fascia, derived from the external oblique aponeurosis and its investing fascia. The constituents of the spermatic cord are ductus deferens, in Latin vas deferens, a muscular tube that conveys sperms from the epididymis to the ejaculatory duct. It courses through the substance of the prostate to open into the prostatic part of the urethra. Testicular artery arising from the aorta, vertebral level of the A2, and supplying the testes and epididymis. Artery of ductus deferens arising from the inferior vesical artery, cremasteric artery arising from the inferior epigastric artery. Pampiniform venous plexus, a network formed by up to 12 veins that converge superiorly as the right of left testicular veins. Sympathetic nerve fibers on arteries on the ductus deferens. Genital branch of genitofemoral nerve supplying the cremaster muscle. Lymphatic vessels draining the testes and closely associated structures to the lumbar lymph nodes. Vestige of the processus vaginalis, which may be seen as fibrous thread in the anterior part of the spermatic cord, extending between the abdominal peritoneum and tunica vaginalis. It may not be detectable in some cases. Layers of the abdominal wall and the coverings of the spermatic cord and testes derived from them. You can see on this picture. The formation of the deep inguinal ring. Corresponding layers of anterior abdominal wall, spermatic cord and scrotum. Look through carefully to determine all the layers and coverings of the spermatic cord and its relation with the elements of inguinal canal, the walls of the inguinal canal. Once again, some important facts about inguinal canal and the structures related with it. Inguinal canal, passage through anterior abdominal wall. Conveys spermatic cord in males and round ligaments in females. Formed embryologically by aggregation of process vaginalis through anterior abdominal wall. Internal or deep ring of the inguinal canal, opening through the transversalis fascial located above mid portion of inguinal ligament, lateral to the inferior epigastric artery. External or superficial ring of the inguinal canal, triangular opening of external oblique aponeurosis just lateral to the pubic tubercle. Hasselbalch triangle area of weakness in pelvic wall. Side or direct inguinal hernias, medial border lateral edge of rectus sheath, lateral border inferior epigastric artery, inferior border inguinal ligament. The sides of this triangle. There are just two types of inguinal hernias, direct and indirect. Indirect oblique inguinal hernia. The herniated lobes of small intestine pass through the deep inguinal ring into the inguinal canal. It may emerge through the superficial inguinal ring and descend into the scrotum. This type of hernia is more common than the direct inguinal hernia and is commonly congenital due to the patent processus vaginalis. The neck of the hernia sac lies lateral to the inferior epigastric artery. A direct inguinal hernia arises from protrusion of abdominal viscera through the weakness of the posterior wall of the inguinal canal, medial to the inferior epigastric vessel, superficially through the Hasselbalch triangle. This type of hernia is termed direct, as the hernial sac directly protrudes through the inguinal wall, in contrast to indirect ones which arise through the deep ring and enter the inguinal canal. Since direct hernias do not have a guiding path, they seldom extend into the scrotum unless very large and chronic. We can compare a direct inguinal hernia and indirect congenital inguinal hernia, their structures and peculiarities. This illustration shows you the following differences. Characteristics of the inguinal hernias. Predisposing factors. Indirect hernias. Weakness of anterior abdominal wall in inguinal triangle. Owing to distended superficial ring, narrow inguinal falx, or attenuation of aponeurosis in males over 40 years of age. And predisposing factors in indirect hernia. Patency of processus vaginalis, complete or at least of superior part, in younger persons, the great majority of whom are males. Frequency. Indirect hernias, less common, 1/3 to 1/4 of inguinal hernias. Frequency in indirect hernias, more common, 2/3 to 3/4 of inguinal hernias. Convergence at exit from abdominal cavity, direct hernias, peritoneum plus transversalis fascia lies outside inner 1 or 2 facial coverings of core. Indirect, peritoneum of persistent processus vaginalis plus all 3 facial coverings of cord around ligament. Course of the direct hernia usually traverses only medial third of inguinal canal, external and parallel to vestige of processus vaginalis, and indirect traverses inguinal canal, entire canal, if it is a sufficient size within processus vaginalis. exit from the anterior abdominal wall. Indirect hernias via superficial ring lateral to cord, rarely enter scrotum, and as about indirect hernias via superficial ring inside cord, commonly passing into scrotum or labium majus. This table is very important in clinical walk-in clinical routine to make the difference, to make the correct diagnosis, to confirm the diagnosis, and we should make a difference between the direct and the indirect hernia. So, the deep inguinal region and the anterior abdominal wall seen from within the abdomen. The brachus, the obliterated portion of the umbilical artery, and the inferior epigastric vessels are covered by peritoneal folds, respectively called the median, medial, and lateral umbilical folds. And the scheme: direct inguinal hernia, green dotted line, and indirect inguinal hernia, purple dotted line. This slide shows you the epidemiological aspects of inguinal hernias. Worldwide, about 20 million groin hernias are repaired each year. This is the American statistic. 1 million of abdominal wall hernia repairs are performed each year. 750,000 inguinal, 166,000 umbilical, 97,000 incisional, 25,000 femoral. 75% of all abdominal wall hernias occur in the groin. Right, more often than left. Male, more often than female. In men, indirect, direct, femoral. Women, indirect, femoral, direct. Femoral hernias account for fewer than 10% of all groin hernias. 40% present as emergencies. Mortality is higher for emergency repair than for elective repair. Of course, it's a rule. Emergency operations are more frequently required for female patients. Hiatal hernia. A hiatal hernia occurs when part of your stomach protrudes up through the diaphragm into your chest cavity. Not your, maybe, patients, I mean. The diaphragm is a sheet of muscle that helps a man to breathe by contracting and drawing air into the lungs. It separates the organs of the abdomen from the thoracic cavity. Umbilical hernia. Umbilical hernias can occur in children and babies. This happens when the intestines bulge through the abdominal wall near the belly button. A bulge in or near the child's belly button, especially when they are crying. When they are crying too much, this type of hernia may occur. An umbilical hernia is the only kind that often goes away on its own as the abdominal wall muscles get stronger, typically by the time the child is 1 or 2 years old. If the hernia hasn't gone away by 5 years of age, surgery can be used to correct it. Ventral hernia. A ventral hernia happens when tissue bulges through an opening in the muscles of the abdomen. You may notice that the size of the ventral hernia reduces when the patient lies down. Ventral hernias can also happen at the site of a surgical incision. This is called an incisional hernia and can happen due to surgical carrying or weakness of the abdominal muscles at the surgical site. The treatment of hernias. The only way to effectively treat a hernia is through surgical repair. However, whether or not the patient needs surgery depends on the size of the patient's hernia and the severity of the symptoms. In some cases, wearing a truss may help to ease the symptoms of the hernia. This is a supportive undergarment that helps to hold the hernia in place. The Bassini technique provides a straightened forward robe is a cost-effective option for limited resource settings. A closely prosthesis and laparoscopic approaches can be avoided. Ultimately, the optimal method for growing hernia repair is the use of prosthetic reinforced mesh. Where access to prosthetic materials is limited, the shoulder or Bassini techniques are both effective alternatives. Yet these techniques present a challenge to the novice surgeon as the learning curve is steep. An inguinal hernia is the protrusion of the abdominal cavity contents into the inguinal canal, presenting as a subcutaneous bulge over the groin. These outpouching could be small, intense appendix, omentum, peritoneum, intestine, appendix, omentum, peritoneum, or a peritoneal lipoma. Inguinal hernias can be categorized as either direct or indirect, as we've discussed before, and based on the course and anatomical location of the herniation. Usually, you should know that usually the mobile organs are the part of the hernia because they can move easily and can exit the abdominal wall through the weak places, through the defects of the muscular-aponeurotic layer. Indirect hernias can be congenital in origin, resulting from incomplete closure of the process vaginalis. To differentiate between the two types of inguinal hernia, identify the location of the inferior epigastric vessels in relation to the herniated sac. An indirect hernia would present lateral to the vessels, and a direct hernia would present medial to the vessels. Remember the previous table with the characteristics of different types of hernia, and of course you will know, you will get the correct information. The approach to access and isolate the herniated sac with each type of inguinal hernia, yet once isolated, both types can be repaired via the Bassini technique. In this technique, the herniated sac is first ligated or invaginated back into the abdominal cavity. Of course, this is the first stages, the surgical approach, and the manipulation that allows to remove the hernial sac, to ligate it or invaginate it. The defect in the posterior wall of the inguinal canal is then repaired if indicated by a direct hernia, and the characteristic suturing method to approximate the conjoint tendon, internal oblique and transverse abdominis aponeurosis, to the inguinal ligament is then undertaken. In other words, we should, when we use the technique of Bassini, we should sew the margins of the internal oblique abdominis and transversalis muscle with the inguinal ligament to reinforce the posterior wall of the inguinal canal. This slide demonstrates you the steps of the hernia treatment. Bassini repair is the classical method, is frequently used for the indirect inguinal hernias and small direct hernias. The conjointed tendon of the transversus abdominis and the internal oblique muscles is sutured to the inguinal ligament. Reconstruction of the inguinal floor by opening the transversalis fascia from the internal inguinal ring to the pubic tubercle, thereby exposing the peritoneal fat. Bluntly dissected on the surface of the superior flap of the transversalis fascia. Then triple layer approximation. The layer of the transversalis fascia and the transversalis abdominis is sutured with the internal oblique muscle to the reflected inguinal ligament. The scheme and the picture. Different steps of the surgical repair by method of Bassini. Then the method by Shouldice. 2 layers. Continuous running suture reapproximates the inguinal floor. A second layer is straightened near the internal ring, approximating the internal oblique muscle and the transversus abdominis to a band of external oblique aponeurosis, superficial and parallel to the Poupart's ligament. The suture line ends at the pubic crest. A fourth suture line may be added. The method by McWade is for the repair of large inguinal hernias, direct inguinal hernias, recurrent hernias, and femoral hernias. The conjoined tendon is sutured to the Cooper's ligament from the pubic clavicle laterally. Similar to the Bassini repair, except that is used Cooper's ligament instead of the inguinal ligament. Interrupted sutures are placed from the pubic tubercle laterally along the Cooper's ligament, progressively narrowing the femoral ring. Treatment of femoral hernia, the last stitching of Cooper's ligament, is known as the transition stitch and includes the inguinal ligament and relaxing excision. Martinov's repair. Martinov's repair involves the suturing of the anterior wall of the inguinal canal. It's better to use this method in children and in female. Spasopokotsky repair. The special type of stitches was offered by Spasopokotsky. And this method was added by Kimborowski. Liechtenstein's repair. This method requires to use the mesh. Key surgical objectives: patient reparation, superficial dissection, access to the inguinal canal, mobilization of cord structures, identification of the spermatic cord, isolation of the hernia sac, resection of the hernia sac, Bassini suture technique, and closure. Step by step. You can see the hernial sac. The surgeon cuts the wall of the sac, finds the intestinal loop within the sac, assesses its condition, and then return the loop back to the abdominal cavity. Then ligate the neck of the sac and cut it. I mean, performs the resection of the sac. The WHO Safe Surgery Checklist is a global initiative to promote patient safety in relation to both emergency and essential surgical care. It aims to decrease errors and adverse events and increase teamwork and communication in surgery. Signing before the induction of anesthesia. Perform a WHO surgical sign-in prior to the induction of anesthesia. The checklist confirms the patient is fully informed and has given the consent. Discuss patient's permanence such as anesthesia risk, allergies, difficulty airways, aspiration risk, and estimated blood loss. Mark the surgical site. Timeout before the initial skin incision. The intraoperative timeout of the WHO surgical safety checklist identifies the key steps that must be completed prior to knife to skin. These include operative team introduction, confirming patient's identity and surgical site, anticipating critical events, and discussing antibiotics and essential imaging. The postoperative sign-out should be performed by the same nominated surgical nurse coordination. It should be performed with the anesthetist, surgeon, and nurse at the patient's surgical table before the patient leaves the operating room. Confirm the outcome of the procedure and complete a swab, a needle, and instrument count. Incarceration. Incarceration means stamped or imprisoned. Clinically, an incarcerated hernia is an irreducible hernia. An incarcerating is not in and of itself a surgical emergency. Many hernias are chronically incarcerated due to adhesion of contents. 100 years ago, the most common cause of intestinal obstruction was a hernia. At the present time, hernia is third after adhesive obstruction and cancer. Hernia is an important cause of obstruction that is not infrequently missed on clinical examination. When a patient with an intestinal obstruction is examined, great emphasis should be placed on adequate exposure of the entire abdominal wall and groin area, from nipples to knees. Strangulation of a hernia is a serious and life-threatening condition in which the hernia contents become ischemic and non-viable. The pathogenesis of the condition involves intra-abdominal contents with the hernia sac. Straining may push more contents into the sac, and then tense sac then causes pressure at the neck. This pressure initially produces venous congestion resulting in edema. Eventually, the pressure is so great that the arterial supply is obstructed and the contents become gangrenous. As you see, we are discussing the complications of the hernias. And the first one was strangulation. Strangulation that can be determined as the one of the types of the intestinal obstruction. Then the Richter's hernia. August Gottlieb Richter in 1785 described a hernia type that bears his name, in which the antemesenteric border of the intestine protrudes into the hernia sac without involving the entire circumference of the intestine, so that intestinal obstruction doesn't occur. The most common site of the femoral ring, 36% to 88%, followed by the inguinal canal, 12% to 36%, and an abdominal wall incision, from 4% to 25%. This picture illustrates you the Richter hernia. Part of the bowel wall herniates through the defect in the abdominal wall. Spigelian hernia occurs along the semilunar line, is rather rare. Ultrasound examination can help you to confirm the diagnosis. Operative repair is mandatory once the hernia is confirmed on diagnosis. Spigelian hernia, also known as lateral ventral hernia, is a type of abdominal hernia along the semilunar line, resulting in herniation between the muscles of the abdominal wall. They may be congenital or acquired. A Spigelian hernia is associated with ipsilateral hyperhism among 75% male infants. The hernial orifice of a Spigelian hernia is located in the Spigelian fascia, that is, between the lateral border of the rectus abdominis muscle and the semilunar line through the transversus abdominis aponeurosis, close to the level of the arcuate line. The majority of Spigelian hernias are found in a transverse band laying 2 6 centimeters cranial to a line running between both anterior superior iliac spines, referred to as the Spigelian hernia belt. Most Spigelian hernias occur in the lower abdominal, where the posterior sheath is deficient. So, my dear friends, we've discussed one of the most topics in clinical anatomy, the clinical anatomy of the abdominal wall. It's rather difficult, but very interesting in the same time. And of course, the abdominal hernias, the knowledge of the abdominal hernias based on the knowledge of the clinical anatomy of the abdominal wall is very important in the daily routine of the surgeon. And you can oftenly meet such kind of patients even in your practice. Thank you for attention. I wish you a good luck. The lecture is over. Goodbye.